Good afternoon. It's a 60-year-old gentleman evaluated for hypertension at 30 years of age and identified to have coarctation of aorta with bicuspid aortic valve. Underwent balloon dilatation of the coarctation in 1997, and then a Ross procedure in 2002 for severe AS with a pulmonary 22 millimeter pulmonary homograft. Suffered an acute MI in 2018 and had a PTCA with stent to LAD. Now he is having class 2 dyspnea on aggression, which has been progressed to class 3 over last 3 months. There is lower limb swelling and episode of dizziness. On follow-up, found to have severe homograft stenosis. Underwent homograft stenting in July 2019. On examination, pulse rate is 80 per minute. Blood pressure is 110/70. JBP not elevated. Apex left 6 intercostal space in mid-clavicular line. S1 normal, S2 single. Grade 2 systolic murmur in pulmonary area and grade 2 early diastolic murmur in pulmonary area. X-ray shows situs olitus levocardia, CTR of around 60%, upturned apex, right atrial enlargement. ECG shows sinus rhythm, heart rate of around 70 per minute, QRS x6 minus 15 degrees, QRS duration 100 milliseconds, bifascicular blood. Echo showing 4-chamber view, apical 4-chamber view showing RARB dilatation. On long axis there is grade 1 MR, no, grade 1 AR, sorry. There is mild TR with a peak grind of around 82 millimeter of mercury. We did a CT pulmonary angio prior to RVOT stenting. As you can see, there is narrowing of the pulmonary homograft. This is the 3D construction of the MPA showing anteroposteriorly compressed homograft. We did a RVOT stenting.
We need more lidocaine.
This is the pre-dilatation of the stenting with a 18 millimeter boa balloon, followed by a putting a Andra stent, 48 millimeter XSL Andra stent.
Lidocaine, no, we haven't touched. Yeah.
Then after that, the stent was redilated within a 22 millimeter Andra balloon. During the redilatation, the balloon got burst and part of the balloon went into the RPA. This is the post dilatation of the stent showing proximal compression. And post stenting coronary angio shows there is no compromise of the coronaries. This is the post stenting CT pulmonary angio showing that anterior posteriorly compressed stent, and there is a filling defect in the RPA, which is the migrated balloon, part of the balloon. And the CT scan showing the coronaries are away from the stenting. The final diagnosis is status post coarctation balloon dilatation in 1997, status post Ross procedure in 2002 with pulmonary homograft, status post PTCA of LAD in 2008, severe homograft narrowing, moderate RBC systolic dysfunction, status post RVOT stenting. So plan is to implant a percutaneous pulmonary valve.
It's 26 is leaking.
Okay.
See, the thing is, there is a check flow.
Successfully.
Shiva, we are back with you after the presentation, so we can hear what you are saying.
Yeah. Okay, so just a second, Chetan. I am trying to get a hemostasis better. Okay. Varakan.
Yep.
Can you run through the pictures
Sure,
from the beginning?
Sure, okay. All right. So so you know the situation, right?
Yeah.
So if you can go from the first angio. So what you can see here now, the stent is quite squeezing in the middle,
24,
and the proximal part is somewhat moving a bit. So if you can see from the CT, is not circular. It's kind of ellipsoidal appearance. So next, please.
We have to take that sheet.
Next, please. So what Shiva did, he tried to get to the pulmonary artery without gelling of the proximal strut by using the J-curve wire like that.
take that
So
out.
it's very clear away from the strut. Next,
You're
please.
pressing again.
And then this is what we try to show you on the unfast view. Unfortunately, this is the most corridor that we can do. And after that, next, please.
Hold it.
Yeah, we pass the 14 French sheath on above beyond the waist, and then we reinforce that area with the covered CP stand. Well, the reason we use covered because in case that we're gonna put the valve
him to
in,
purchase another
and
24
in case that
hook sheath
that
because,
area
we
is
need it for the
easily
sinus
to
necessary
get
stick.
breakable after we dilate more.
Sister,
So
wait.
then we have no chance, to avoid like a breaking of the calcium. So that's why we prefer to have the cover stand. But another issue happens now. You see that the balloon is milking back down. Yeah. Next, please. So what Shiva did actually, so we try to stabilize the balloon position by deflate the balloon and then push the sheet up. But unfortunately, it's not really the way. Next, please. Then eventually, by just
22?
inflating the balloon and keep pushing
22
the balloon assembly system, it looks like that. So it's more stable proximally, but distally, you can see it is not open at all. Next, please. So next step, we deflate the balloon and deflate completely. And then next, please.
22 into 2.
And then what we're trying to do now, we
give
try to advance the balloon, to the more distal area, while supporting with this 14 French sheath. And then you can see that.
And this is a covered
for a
stent, so
second.
the flow across into the pulmonary artery is just through that small lumen of the covered CP stent.
Yeah, of course. Of course. And that time, because the blood pressure is a bit down, but it's quite stable. I mean, like blood pressure about 80 something systolic. So we have few times. Next, please.
Okay, hold it.
Yeah, eventually
want
we
that
lucky enough to put the balloon,
RCA catheter
in the right position, and then we just do the same way as usual, and we inflate the balloon to the maximum. Yep.
Things
Yeah,
speaking.
please.
In this case, I have several types of complication. I remove the balloon and put a small and new balloon, and I can cross the smallest one easier. And if you try
Yeah.
to boost the previous balloon, maybe you can lose everything. Something wrong.
Yeah, so that's the thing thank you, Tin. I think that's the thing that we consider as well.
We
But
have to wait till
because
he
the distal
completes.
is not flat enough, so we also have a problem. I mean, possibility that once we pull the balloon back, so then the stent is coming back too. So that's why we thought probably we try this one first. If it doesn't work, and then we try what you said. But we're lucky enough. Then so we put atmosphere inflation here, so you can still see the waist. So next, please. And then that's the final, dilation diameter after we just finished implanting another stent. So the question to you now will be, yep, please.
I wanted to make one comment.
Please,
You know,
please, Bharat.
rather than trying to treat this complication, I think this complication to some extent can be prevented. I'm not saying 100% it can be prevented.
Yeah, of
but
course,
to some
definitely.
extent. What happens is when you crimp a stent, many times in order that the stent should not migrate from the balloon, you tend to be little over-enthusiastic in compressing. And in doing that, you lose the continuity between the proximal part of the balloon and the distal part of the balloon across the stent. So it's always a good idea to first go on the negative, compress the stent, and let the negative go, and look for the water meniscus moving across the stent.
Yep.
The second thing is, if you are doing dilatation on a routine balloon, a valvuloplasty balloon, then it may not be a bad idea to keep a part of the balloon in the sheath so that the first dilatation is always distal, and then you can withdraw the sheath gently and do the
I see.
dilatation. And third, of course, if money is not a
Yeah.
consideration, big balloon is a good idea, wherein this complication is rare, not never known, but rare as compared to valvular.
Yeah,
Dr. Bharat, can I make one point? The reason why we selected a reasonably slippery balloon called BOA was because it was a 22 millimeter balloon, but it was a 9 French compatible. So since I am taking a covered CP stent and my sheath was 14 French, if it is a 9 plus 4, so it is 13. So it will not get caught into my 14 French sheath. So that was the logic behind choosing this particular balloon and Lunderquist. So the reason for choosing that slippery balloon was because it was lower in profile. I fully agree that a Z-Med or a bib would not have done this, but
you could have gone on a 18 mm Z-Med as an initial this thing and then post-dilated with 22.
But Shiva, here
18 mm Z-Med is 10 French compatible.
Yeah, and you have a covered stent, easily goes through 14 French.
Possible, yeah. Since our, yeah, correct. I think retrospectively what you said was 100% correct. Since I have previously dilated this stent to 22 millimeter in my previous dilatation, I just wanted the same 22 to match it so that, you know, it approximates in all the areas. But I completely agree with your point.
Shiva, what is the hemodynamic status now after your two stents are across the right ventricular outflow tract? What is the pressure?
No, there is more story. Varakan will tell more stories.
Okay, go on.
Yeah.
Okay. All right. So just go for furrow then. Before
Go on to that. Go to the first. Go to the first.
the first one. Yeah.
Okay. No,
and
go
then
next.
Keep following.
Go
Because
for-
if you
next.
remember by the
Next.
Next. presentation, we still have the
Next.
the
Next. Okay. Stop.
the distal part of the balloon previously,
Previous.
which is ruptured,
Next.
still in the right pulmonary artery.
Stop.
So we discussed that with
Run.
Shiva. So he suggests that if we don't do it today, we may not be able to do it because once we think about implanting the valve, and then even if now there's no hemodynamic significance in terms of the residual, you know, chunk of the balloon at the RPA, but he thought probably if we should try our best to make it take it out, and then it would be a good
Absolutely.
strategy today. Yeah. So you saw that, right? The
Yeah.
filling defect on the RPA. So the challenge here will be we don't have the marker, so we need to just not that blind, but at least, you know, randomly trying to do it, you know, to catching that kind of chunk of the balloon. Next, please. So initially, next, please. Next, please. So initially, as you can see, there's an assembly of the you know, gooseneck snare 15 millimeter together with the guiding JR catheter, and then, you know, that was Shiva's kind of fishing skill actually, because you know, he's very keen on fishing, and as you can see now he grabbed something, and he feel that. Next, please. And then you know, we try to pull it back, and as we already aware that it will be, I don't know, first thing will be, I don't know, we don't know exactly where did we catch, and the second will be if we just trying to pull it back now into the sheath, it's likely we cannot pull it back. But if you won't pull it back and you try to pull everything back, it may catching somewhere. But with that kind of, you know, a lot of discussion, we try to you know, to pull everything all together until it's reaching the sheath, 24 French sheath at the IVC. I mean at the groin. So we'll see what happened. Now after we pull it, you know, the 14 French sheath, balloon. I mean the snare, and then it's catch with the strut at the proximal end. So now we cannot pull back anymore. So we decide to, you know, remove the Lunderquist wire. Next, please. And then you think we check it. So it's likely now that the balloon, chunk of the balloon is in the stent, but catching the proximal part of the strut. Next, please. And then we try to just likely pushing and pulling and keep maneuvering, and then we're lucky enough to, you know, bring the everything back. Next, please. So with that, once we reaching the IVC, eventually, because of the you know, the snare cannot catch the balloon properly, so then we lose the balloon chunk of the balloon here. You see that there's a filling defect there.
Yeah.
So what we did, we try again to fishing around this area, and without successful attempt from the very beginning, it's very difficult to, you know, to catch it. Next, please. So now you see the balloon is still at the ostium of the sheath. So it means that for some reason, as maybe Bharat mentioned previously in his talk few times, that it may cause some kind of accordion effect. So that's why even if it's 24 French sheath, we cannot just pull it back. So next, please.
This is
So
the catching.
yeah. So now we just try to catch with hope that if we can catch a good grip, and then we can pull it back. But so our plan B will be, if we cannot do it here, we will try to go from the neck also, just to stabilize the balloon, the shaft, and then we try to just slenderize it and coming back. But now we're lucky, we catch it, and then we just trying to pull everything into the 24 French sheath. It's quite hard actually to pull it back. Next, please. Still not be able to do it. Next, please. Next, please. Okay. So now, so I at that time I thought, may I try to fish then? So I
This was
asked Shiva-
Varakan's catch.
so I asked Shiva if I can try. So eventually, I'm not a good fisherman actually, but I was lucky enough to pull it back into the sheath, as you can see here. Right, and then next, please. And it's still stuck on the valve. So at that time, I think it's not reasonable to do more harm to try to pull it back. So we take everything, the sheath, 24 French sheath out of the body. Next, please. Next, please. There, so it's inside. Next, please. Okay, so if you can see, that is the
Transverse rupture.
that was what we have inside the body. Yes, you saw the picture, right? Okay, so now we were lucky enough to deal with the residual balloon, and then the next plan will be we should dealing with the waste.
So looks
in
like
order to,
Shiva is
be
collecting
ready for
cases
valve
for nightmare
implantation.
session, eh?
I hope it doesn't become a nightmare today and it becomes a sweet ending, like lateral view. Lateral view. With Varakan in my side, I don't think there will be any nightmares and all. It's going to be thoroughly
We'll do our best.
enjoyable afternoon. Okay, now the plan was 22 Atlas.
But Shiva, before we tell our plan, so may I ask the audience and the panelists, because now we have two stands in place, and you can see it's still moving. It's not very rigid platform. So the question will be, should we have another stand to stabilize that area, or that's enough?
I think where's the landing zone?
Chitra,
we
what do you
intend
think?
To put the valve.
I think you got a fantastic position there.
Yeah, I think at the waist.
10.
You got a good waist there.
Mm.
I would put the valve just where the waist is. I don't know what everybody else thinks in the audience. Bharat, any comments?
Go to 12.
As you asked very
30.
beginning, what was
Enough,
the
enough.
Yeah,
it was a good idea to know
yeah.
what the hemodynamics was.
Okay, the hemodynamics was
Tell me,
the hemodynamics was 50 millimeters, 50 millimeters of mercury at the right ventricle. There was a 10 difference between the pulmonary artery and the right ventricle. The question is, we want to optimize the stent for taking a 23 millimeter 23 millimeter valve. So that was the reason why we wanted to post dilate.
And no, I think post dilatation is not a bad idea because otherwise the valve longevity also is an issue if you put it in a stenotic stent. So if you can get rid of that stenosis as much as you can, that would be a good idea. I would probably do the same.
Yeah. So okay. So what I am going to do now will be, I will advance a catheter across
Shiva, the question I
to
wanted
measure the
ask you
hemodynamics.
is that whether that other stent
Yes.
got fractured,
Yes.
because you see the way the proximal part of that stent, which is not a CP stent, some other stent, the way it is moving.
Yeah, that's an Andra. That's an Andra XXL. We discussed with Dr. Varakan about whether we will put in another stent for the proximal part. But you see, the place where the waist is there is the original annulus. I'll show you. There is a calcification just outside that annulus. That is the location of the valve.
Yeah.
This is somewhere in the right ventricle. And if there is no significant, not this one, I want a large guide catheter, 8 French guide, 7 French, some big guide catheter.
Shiva,
And a
can you
three-way.
put a multi-track
So
on this
if,
wire and do a pullback gradient and show us where the gradient is? And what you want to be reassured is there is no gradient when you pull it back across that Andra stand into the RV.
Because even a proximal
Chetan, I am coming with a
gradient,
multi-track.
Shiva, even a proximal gradient, Shiva, is not good for the longevity of the valve. Because all the
I'm-
premature degenerations of the melody means if there is a proximal gradient, there is a premature degeneration of melody. So I think creating a very good landing zone and spending time on it is not a bad idea. And one more comment I wanted to make, when you put a covered stand and keep on increasing the size of that conduit, it's also not a bad idea to look at the coronaries as to what is happening to the coronaries when conduit gets bigger and bigger.
I think that comment is
Yeah,
especially true for Ross patients.
Yeah, you are talking about the coronary, no, Dr. Bharat?
Because as you
Hello?
keep on, yes, it is coronaries. I am also talking about the
Dr. Bharat, actually the coronary on the CT scan was far away. I will show you the LED stent where it is. You see the LED stent, the posterior most end is the LMCA, and it was just far away, nowhere in relation on a CT scan. And in fact, we had done a balloon interrogation during our previous like stenting, and it was far away.
And where's the
So right now, what I'm showing is a multi-track. I'm going to be showing pressure. Show the blue pressure. Blue pressure. Blue pressure bigger. So this is the right atrial pressure, which is about right now 12 millimeters. We are walking into the right ventricle now. That is the right ventricle below the valve. It's about 30, between 30 to 35. So now I am walking through.
Twenty-three, he said.
That is between 28 to 35. Every alternate beat is going to 35. The other alternate beat is going to 28. Varakan, did you see that? I was catching the lower end of that collapsing stent.
No.
No. Fluoro, store this
That's a
last one
gradient.
and show me that last.
I think Shiva, that is
Show it
one of
bigger.
the that is one of the that is one of the concerns, that your flail segment of that proximal stent is going to catch on even your valve implantation. So you need to decide, are
Yeah,
you going to
but,
leave it as it is?
Yeah, I feel that we will be able to take care of it when we are going by giving a gentle like slack on the wire and adjusting and going in. So in terms of gradient, it looks okay to me. I'm going to make now a pullback from the PA back into the RV. See, this is now in the PA. The PA pressure is like 30235. I'm coming to the right ventricle.
That's good.
Not, I would say there is no gradient practically.
I agree.
Okay, so now I am taking this out. So Dr. Varakan and me, we feel that as soon as we reach the right ventricular outflow tract on a lateral view, we will, in fact, one more thing is this Merrill valve is a deflectable valve. So if at all it is catching, then we will try to deflect it. The original intention is not to deflect at all and take it straight and just give a slack on the wire so that I move to the inner lumen of the stent rather than walking along the edge of the stent. Oh, the valve is ready?
Shiva, can you tell us
minutes.
more
So
about
they
this
want 2
valve?
more
Because many in the audience, including me, probably are a bit ignorant about this valve in terms of what dimensions are you using, how did you decide to select the valve size, the diameter.
Okay, so what happened was, since we have put in a 22 millimeter atlas, And let us see the 22 atlas deflation sequence. Show 22 atlas. Like, see, this is the full 22 atlas. Let us see whether during the deflation, with our eyeballing, we did not find a recoil. Now you might ask, why don't I do a measurement? For a measurement, I need a marker pigtail maybe. Okay, let us give a marker pigtail while he's give me a marker pigtail. So the moment I put in the marker pigtail, give me a measurement, Bhushan or Raghu or one of you. Actually, we wanted to show one live non-fluoroscopic ASD in the lunch-on session. However, the first patient was found to be unsuitable for this procedure by the expert, and so we have swapped it to the second patient, and that is taking a little longer time to.
We are enjoying what we are seeing, so don't worry, Shiva.
Okay, so take measurements. Come, hold it. Chetan, the purpose was to give you more entertainment with Dr. Pan because he does some phenomenal work without any radiation. They are ready to go live. Okay, actually the other side, Dr. Pan is ready to go live. So just go there. I will come back with more details here.
Shiva.
Swap to the next lab.
So after we left you, so eventually we put the valve in without that difficulties, because as you can see, there's a little obstruction while we're trying to pushing the valve in, but by wiggling and also just keep snacking with the wire, just keep pushing and pulling, and then the valve went through very nicely. And after that, so we decided to put the valve just in the middle of the waist. So that's how we align the valve. So we're just slightly inflating, and then here's when we fully inflate it. But with that, that was my first time doing the balloon dilatation, implanting the valve. So I don't have enough power to just fully inflate it in terms of the volume. So that's why, so after deflating it, so the company suggested to probably inflate it more in the full volume in order to make sure that the valve diameter is reaching the 23 millimeter diameter. So that was a second inflation after the first balloon. But unfortunately, after we did second balloon inflation, we get measure the pressure, and unfortunately the pressure looks as if the right ventricle and pulmonary artery look pretty much the same. So we worry on that. So then we did we did an angio, and as you can see here, it looks as if all three leaflets doesn't work at all. So with that, then it's come to an issue of what happened. We don't know exactly. We try to discuss, but don't know exactly. But one thing that you may have seen, that there's a fracture here around the proximal part of the stent previously that was moving. So with that, then we decide to just thinking about reimplanting another valve. But before that, we need to make sure that all the proximal part has been secure. So that's why we put another covered stent, a CP. I think this is 5 centimeter long with the balloon, the previous balloon that we used. This was about 22 millimeter balloon. So we did inflate it with the nominal pressure. And then after that, I think we had a very, very nice landing zone. And then with that, after we have the secure landing zone, the second valve has been inserted from the groin. This one is 24.5 diameter valve, but we intended just to implant it with a diameter of 22, 23 only. So again, there's no issue on the advancing the valve into the position. So once we secure the position, and then we just inflate it at the same, almost the same position as the previous implantation. And as you can see, after that, we got very nice pressure, I mean, holding the PR, there's no PR at all. When we have a look on the angio and also from the hemodynamic measurements. So that's the last angio that we had. So eventually, again, happy ending with 2 valves. Unfortunately, again, as we said, we don't know exactly what happened to the previous valve that not functioning at all. But eventually, we finalized with implanting the my valve in the position. So the gradient between the MPA and the RV is something about 15 millimeters. So we decided to accept it, not to do further balloon dilatation in order to avoid another malfunction of the valve. So that's all for us. To you.
Just a brief question.
Hello?
Yeah, Varakan.
Yep.
Yeah. So how many times does it happen that the valve doesn't function? Do you have any experience? from any
Well,
other
this
case?
is my first time using my valve. So for me, this is, well,
Oh, in any other
50%.
venous valve.
So I
or
can't.
Any other valve?
Well, other valve, I have experience of venous valve. Actually, one of the cases that we did, the valve is not, expand. So we use a balloon to just oppose the valve, and that also caused a problem of the valve function. And that was one case that I had. And this is another case that I had, but that was this was just the my valve. So I can't comment on that clearly. So if
But-
anybody can share the ideas, that we appreciate.
So anybody from the floor, Dr. Suresh, Dr. Krishnamurthy, any comments? What you suggested in the other case also, there was balloon dilatation, post dilatation, which led to the problem, and here also. So do you think that over dilating later may be a problem, or that is a routine procedure which should be done in all such cases to make good apposition of the valve?
Well, to be honest with you, I think first balloon inflation will be the most important thing. So if you can do your best to inflate to the nominal volume, and then you just leave it, that would be the great a way to avoid the complication of the valve malfunction. But to be honest with you, I have very limited experience, and I can't completely say what happened and how can I or you avoid it.
So it's good that the patient doesn't have too much of a problem, but what happens to this mass of metal which
Yep.
you have created, and what will be the strategy to have IE kind of suggestions? Thank you, Borakan. We'll have our discussion in the hall. We'll move to the...
Thank you, sir.
Thank you.
Thank you, sir.